This is part 2 of chapter 22, selected sections from that chapter. So, oral medications. The best way to give an oral medication is to use a plastic disposable syringe. You'll see for home use they have teaspoon-shaped ones and many different types, but the plastic disposable syringes are the most accurate. That's what we're going to use at the hospital. With an infant, we are worried about aspiration, so sit them up, don't leave them laying down, and then you're going to put the syringe along the side of the cheek or along the side of the tongue and give it slowly, just a little bit, and make sure that you see them swallow before you give more. Parents will often say they want to put it in a bottle. The problem with that is you have no way of knowing how much the child got. If the child takes half of the bottle, well, do you say they must have had half the medicine? If you don't dilute it very much, so it's pretty concentrated, so you'll know they'll take the full amount, then you tend to get a lot of bad flavor and they won't take any of it, or they'll take a couple sips and refuse it. So that is not really a good way to give it, just because you can't be sure they'll get all of it, or it may take an hour to get it all in, instead of it all being in, just a minute or less. With young children, we often do need to use mild physical coercion. We may need to, hold their hands down so they can't push it away, squirt it in, hold their head still till they swallowed, not let them spit it out. We are talking about atraumatic care, but getting well is less traumatic than leaving them sick, so we do need to do this. We just need to do it in the least traumatic way that we can. And here's pictures of lots of different things. I think you can see my cursor as it comes in here. This is a 1 ml syringe, and this is probably either a 3 or a 5. Those are really the most accurate ones for using. And here's a nurse or a mom holding that child's hand out of the way. Sometimes it's going to take a second person because one may have to hold the head still too if the child's thrashing their head. But you can see she's got the child pinned against her body, using her body as well as the free hand to hold the child. Eye drops, these are not very different from what you've done with adults. It's probably easiest to have the child lay down, as opposed to with adults often we have them sit up and just tilt their head back. But you're still going to make that conjunctival sac and drop the drop in there with the child looking a different direction. So usually having them tell them to look, up so that they're looking towards their forehead. Just name a spot on the wall if there's something on the wall, or having them look far to the inside towards the bridge of their nose, something so that they're looking, you're not going to drop right on top of the cornea. Nose drops, not very common, but we do occasionally give something like neosynephrine, which is a nasal drop, if the child leans their head down. So either if it's a very small child lays across your lap with their head hanging down, or have an older child lay on the bed with their head hanging down, that's going to be the easiest way to get in there. And sometimes you can convince kids that this is good because it won't run down their throat, and they won't get a lot of the flavor like with the nasal mist kind. They may actually be an older child may be more compliant with this than something that sprays mist. Okay, giving intramuscular shots, intramuscular administration of medication. We do want to use as small of a needle as possible. With kids, we're usually using 3/8 or 5/8 and maybe a 25 gauge, so smaller than we're using with adults. We do still need to think about the volume as well as the viscosity and, pick accordingly. But usually with kids, we're also talking about smaller volumes, so those smaller needles usually will work. On infants, we give shots in the vastus lateralis. That's the only place you give them. I believe your book says after age 2 you can start giving them ventrogluteal. At Children's Hospital, the rule is they have to have been ambulating for 1 year so that muscle is well developed. So you're talking about the same age, so 2-ish, before you can use that muscle in the hip. When giving a shot, you pretty much, unless it's an infant who doesn't know what you're doing, you pretty much are going to have somebody help you. Here's a nurse giving a shot in that vastus lateralis. She's using her body to kind of pin down the upper body and her free arm to hold down both legs, because they could kick with either leg. I would say she'd be better having somebody else hold. That's a little risky. Okay, giving medication by IV, not much different than adults, except we're usually talking about much smaller concentrations and obviously slower rates of medicines. We're also mixing them in smaller amounts. At Children's, you'll see peripheral IVs, peripheral venous access device, and they'll call it a PIV on the charting. Any PIV, we're going to use saline if it's not running continuously and do a saline lock. Any central line, we're going to flush it with heparin. And you need to look at the policies, because depending on what it is, it can take 1 ml of heparin, 2 mLs, or 5 mLs. And depending on how much the child weighs, it can be a half unit of heparin per ml, 10 units of heparin per ml, or 100 units of heparin per ml. So look at the policy before you give any heparin flushes. You'll see a lot of PICC lines, peripherally inserted central catheters, at Children's. And these are put in out in the periphery, but threaded right up to the superior vena cava. So they are a central line, and we would flush them with heparin. Now, the flushes are only if it's not in use. If you have continuous fluids running, you don't need the heparin. They'll also have some long-term venous access devices, central lines. The types that you'll see at Children's are Broviacs, and this is really a brand. There's also Hickmans and Grishongs that they use in the adult world, but in pediatrics we use Broviacs, and Metaports. When you have a central line, we use that pink tape and tape all connections, just for fear that a kid's going to get it and twist it and disconnect it, and then know they did something wrong, so they won't tell us, and then the medicine goes all over the bed, and the child doesn't get it, and hopefully he didn't take off the cap, in which case there would also be blood everywhere. Okay. At Children's Hospital, IVs are documented every hour, the amount of solution as well as the site. That also goes for anything that's running continuously, like an NG or a GT or an OG. With the new electronic charting, that is not something we can currently do. Hopefully that will change, and they'll get the charting set where we can do that. But the nurses kind of keep an eye on the clock, and right about the hour, they go through and check all their rooms and jot down every IV, how much has gone in. We don't want to risk having a mistake that goes on for hours and hours. So every hour, and we also want to make sure those sites are good every hour. When you come on, one of the things you'll see the nurses do, if you get to see shift change, is after they finish report, they'll go through, usually before the other nurse leaves, usually the two nurses will do it together, and verify that every IV is the correct solution, whether that's an IV solution, a TPN running, lipids, and that the rates are correct. Here is a picture of some sort of very caustic medication that infiltrated, and you can see the damage that was done. Here's sort of a schematic of where the Broviac goes. That's what a Broviac looks like. It usually enters at the superior at the subclavian and then threads to the superior vena cava. They can tunnel it underneath the skin, though, pretty much anywhere. If a kid's had several, they may move it somewhere else just to get away from scar tissue, or if there's a cancer in an area, they can thread it underneath the skin. They can also poke right or left for your subclavian. Now, feeding tubes, whether it's nasogastric, orogastric, or a gastrostomy tube, we will look at those. No, I guess the other ones are pictures. It's nice if a kid's getting oral medication to give it down the tube. If it's ordered PO, that does mean, by mouth, but it goes by mouth right into the stomach. We can put it down a tube right into the stomach. That really is the same route. So it's nice if we don't have to force a kid to take medicine they don't want. We can just squirt it in their tube. We do want to check placement, and at Children's Hospital, the protocol says to check with 3 mLs of air. I believe it says 3 to 4. So if you've got an NG or an OG, you're always going to check placement with air beforehand, as well as check aspirate. There isn't pH paper. I know that's what we teach in Skills Lab, but there isn't any at the hospital to check that. You're just looking for volume to make sure they are absorbing and digesting. Flushing, your book and everybody will talk about needing to flush to prevent clogging. What you're going to see most of the nurses do is flush with air, and that is the policy allows them to do that. They don't have to use water. We just don't, kids need calories, they don't need free water, and flushing with air seems to work. We all swallow a lot of air when we eat. It's really not a concern putting a little air in the stomach. We're only talking about a couple of mLs. And putting in a tube is just like, measured just the same as you do for an adult. With infants, we usually will go orally rather than nasally. And an older child will go nasally, but use the very soft silastic ones, and those have a guide wire that you have to squirt down a little bit of saline first, and it's got a self-lubricating lubricant in there, and then you take the guide wire out. This is a Mickey, and this is the type of gastrostomy tube you'll see most commonly at Children's. The nice thing, it's got a plug sort of like a beach ball has, so if it's not in use, it doesn't have anything hanging out, and it lets the kids dress normally and play normally without worrying about, some tube catching. And then you just sort of open that beach ball part, and it's got a connector that hooks in there, and then you hook your feeding up to that. This is the other type of gastrostomy tube where you've always got something hanging out, and this is showing a little bit of granulation tissue at that stoma.